Good morning, everyone. We're going to give just a few minutes for everyone to get on, and then we'll get started. All right, we're going to go ahead and get started. Good morning and welcome to today's Recovery Summit session. This webinar is part of the Recovery Summit series hosted each September by St. Clair County Community Mental Health in recognition of National Recovery Month. A few quick reminders, today's session is being recorded and will be available on the St. Clair County Community Mental Health YouTube channel sometime in October. Please use the chat box for any questions or comments. Our presenter will address them as time allows. For those requesting continued education credits, please be sure to remain on the webinar for the full session and complete the survey that will be emailed to you. We're honored to be joined today by St. Clair County Community Mental Health's Senior Psychiatrist, Dr. Mohammed Saeed. Welcome, Dr. Saeed.
Thank you, Christy. Good morning to everyone. So we are here this morning to answer some basic questions. And those questions are, why do people get addicted? And what are the pathways to recovery for youth and adults? So let's get started. By way of disclosure, I have not received any compensation or any gifts from any drug companies, agencies, or organizations. Some of the treatment options I'm going to discuss today are off-label, which means they are not FDA approved. So what are the objectives of today's presentation? To define and understand the cycle of addiction, to understand different concept or theories about causes and mechanism of addiction across lifespan, to learn about different pathways of recovery, to understand who is at most risk. And then finally, what are evidence-based strategies for prevention? Here are my references. So before we talk about why do people get addicted, I think it's appropriate to ask a even more basic question. What is addiction? And I use the word addiction in not to disrespect anyone, but it is the same as substance use disorder diagnosis used in DSM. So, what is a substance use disorder? There are many definitions. You can consult the textbooks or Google or learn about it. This simple concept I find quite useful. If I remember 4 C's of addiction or substance use disorder, the concept of what is addiction becomes clear in my mind. So the first C is control, the second one is compulsive, the third one is consequences, the 4 C stands for cravings. I have a gentleman I am treating. He works very hard, physical labor, and he earns good money. But when the payday comes, he is excited on that day. As he wakes up, he's anticipating getting that paycheck, and he cannot wait to leave work and go to the party store and buy his lottery tickets. Uh, he spends almost entire paycheck on the lottery tickets, and this has resulted in he is not able to afford an apartment. He is having issues with relationships. He is always financially strained, uh, and he knows that. But in spite of this, he has lost control over this gambling that he engages in. Uh, Compare that to a lady I know. She goes to Las Vegas. And when she gets there, she sets aside a certain amount of money. I don't know, maybe it's 500 or $1,000. And she says, this is the amount of money I'm going to spend on my gambling. And when that money ends, she stops there and then she spends the rest of her time in Las Vegas, going to dinners, watching shows, or doing other things. And then she comes back home. And then she is not gambling for the rest of the time until she goes back to Las Vegas a few months later. So this is an example of somebody who is engaged in gambling, but she's able to start and stop it at will. So what is compulsive act? It's use of a substance or a behavior. There is an irresistible urge, especially one that is against one's conscious wishes. A lady came to see me and she was having issues with alcohol and opiate addictions. And I remember her words. She said to me, I know in my mind I don't want to do this, but my brain just takes me there. But my brain just takes me there. In other words, it is against her conscious wishes. I am also treating a gentleman who has some issues with using cocaine, and his mother came to see me, and she was in tears. And she explained that her son, who lives with her, he has been selling her television, her stereo system, and other items from home, and when she brings it to his attention, when she tries to talk about it, he becomes very agitated, aggressive to the point that the police had to be called. So this gentleman is pursuing his cocaine use or abuse to the point that the consequences of his behaviors don't matter. He's ruining his relationships. He's getting into trouble with the law. He is having a lot of family tension, but the consequences don't seem to matter. So why do people keep coming back to using substances? Because when they try to stop it, they develop a strong desire to get back to using substances because staying away from substances produces significant issues with withdrawal. So who gets addicted? So there are a lot of people who drink alcohol or do other things, or gamble or do other things. Uh, uh, but only 1 in 5 individuals who abuse substances get addicted. I repeat, 4 out of 5 individuals who are drinking are not going to end up with a diagnosis of alcohol use disorder. It's only 1 in 5. Individuals who start using substances, including tobacco or cannabis, before the age of 14 have a much higher risk of developing addictions in adult life. This is a very important point and take home message. Any abuse, any use of substances starting before the age of 14 has dire consequences, and we will talk more about that later. Prognosis for recovery is poor for those individuals who start using substances before the age of 14. So, what's going on inside the brain of a person who is getting addicted? So, this is a simplified diagram. It explains a basic principle of pleasure. So let's say I like vanilla ice cream, for example, and I eat a bowl of vanilla ice cream. What's happening inside my head? While I'm eating my favorite food, the brain, like my body, my mind likes what I'm doing. I'm enjoying that taste in my mouth, and that gets translated into release of dopamine in the reward center. So if you notice, this is the yellow little dots running around in the white area. That's the space in between two neurons called synapse. and they are floating around and they're hitting the receptors of dopamine here. And so this is a normal phenomenon. Now look at this area here. And if you notice that when somebody is using cocaine, the space between two neurons is literally flooded with small little those yellow dots, and they represent dopamine. So dopamine is like you short circuit the system to get a flood of dopamine in your system that gives you a buzz, and that buzz is such a pleasurable feeling that you want to keep going back to that again and again and again. So this is another structural look at what happens in the brain. This is the area of the reward center called extended amygdala, which contains many structures in it. This is basal ganglia, and this is the prefrontal cortex. Uh, this is a busy slide. The point of this slide is that the concept of reward center or pleasure center in the brain is very complex. It is interconnected with many other centers in the brain. This is the ventral tegmental area. This is the ventral pallidum. This is striatum, which is got the ventral striatum and dorsal striatum. This is the different parts of the prefrontal cortex. This is amygdala. This is hippocampus. So the point is that all these different connections are contributing to the player and reward system. It is not a simple one track. There are multiple interconnected pathways that lead to this final outcome. This is another slide to explain in a perhaps simplified way of what's going on in terms of neurotransmission in the brain. I draw your attention to this light green balloon here, which is titled dopamine neuron. These are the nerve cells in the brain that contain the neurotransmitter called dopamine. And I also draw your attention to this bullseye here, and it says dopamine receptor. So in a simplified way, what we are trying to show here is that when dopamine neuron releases dopamine, which comes out, when dopamine comes out and hits the dopamine receptor, that is the starts the feeling of pleasure. And in case of a person who is using substances, for example, cocaine, the buzz or the high that they feel, this is where. So the point I want to make here is, let's say that a person is using smoking cigarettes, and cigarettes act on the acetylcholine neuron, and there is your nicotinic receptor, there is muscarinic receptor. And what the point here is that no matter it starts with smoking, which doesn't have anything to do with dopamine directly, but the acetylcholine receptors ultimately are located on the dopamine neuron itself. Same way, the cannabinoid ultimately ends up in the dopamine neuron, the chain of the chain of reactions ends up in the dopamine neuron. If you're using opioid, it ends up there. If you're using other substances, alcohol, all of these substances, all of these neurotransmitters through a cascade of the cascade of events ends up in the dopamine neuron, and the dopamine finally is released, which goes to the dopamine receptors. So this is a simple slide for a PET scan of the brain. This is a controlled substance who has no issues with substance use, and this is a person who has been abusing cocaine. I draw your attention to this area. This area, which shows there is the reddish area, shows that there is a dopamine, D2 dopamine receptor occupancy. That area is lighting up red, showing that there is some dopamine being released there. After cocaine use, the dopamine has been released so much that the dopamine receptors are kind of depleted. So there is the you don't see the dopamine receptor activity as much here. This is a person who, this is a control again, and this is a person using methamphetamine. And once again, point being, substance use causes brain changes. Substance use disorder is a brain disease. We can see the changes in the brain at the biochemical level and neurotransmission level. One more time, this is a controlled substance, controlled person, and this is after cocaine use. And uh, so I want to point out, although there are structural changes in the brain, although there are neurochemical changes in the brain with substance use, look at this. This was how we started. Without any substance use, you have dopamine receptor activity there. After using cocaine, the dopamine receptor activity is almost not visible. But 4 months after stopping cocaine use, some of that activity is coming back. So, what's the take home message? Recovery is possible. Yes, substance use is a brain disease, but there is recovery, and we can demonstrate it in research showing that there is significant improvement in the brain changes if a person is able to abstain. So, to put it all together, how does everything fit together, which results in a person getting addicted? Of course, biology, family history, and mental health issues play a role. We'll talk more about that in a bit. And environment has a significant role, and I can't emphasize enough about the role of chaos and tension and abuse at home. And parents use. How do our children learn? They learn by modeling. What does that mean? They do what they see, not what they hear, what they see. So if a parent is using cannabis or drinking alcohol, and then turns around and expect the children not to do the same, that is not a good model, because the children see and children follow what they see. Parents use and attitude makes a difference, a big difference. Peer influence makes a big difference, community attitudes and low academic achievement. Okay, now the all these factors contribute to uh, sort of experimenting with drugs, and the early use before the age of 14 has very serious consequences, and that's one of the things that we want to emphasize in today's presentation. So, why do people get addicted? Well, there are many theories that we have come up with. One theory that my profession, medical profession, has believed. We used to believe that much more frequently than these days. That individuals who are using substances are basically trying to treat. They are going to self-medicate their underlying mental health conditions. For example, a person who has social anxiety disorder, he finds it very difficult to be around people. He gets very anxious. He starts drinking so that he can, his anxiety calms down, and then he goes and socializes. Uh, I had an individual who had panic disorder. He could not stand the idea of being confined in any place. So he could not go to a barber to have his haircut done. So what he would do is he talked to his barber and he said, I will be your first customer before anybody gets in. And before he would go for his haircut, he would drink some beers, uh, go up to the barber shop and tell the barber, leave the door open. And he will sit in the barber chair, uh, kind of make himself sit there until the haircut is done. So this was his way of calming his panic attack so that he could manage his life. So, the same way, some people believe that people who are using methamphetamine, they may be treating their underlying attention deficit disorder, they may be treating their mood disorder, they may be escaping from unresolved grief and loss issues, or to cope with the flashbacks from previous trauma, PTSD. The next part is a difficult subject for many of us in medical profession. The fact of the matter is that we in medical profession have been promoting and telling our patients, here is a prescription for opioid analgesics, and the drug companies joined in and they promoted these drugs. And the drug companies and the medical profession, hand in hand, we preached to our patients that these substances are not habit forming, they're not addicting. We all know that is not the case. But nevertheless, this has been done for many years, which resulted in many individuals suffering from getting addicted, suffering from consequences of addiction. This is perhaps a dark chapter in our medical profession. So people also start using substances to cope with demands of life. Some families have a higher disposition for these things. Some families have different enzymes. I know some families where a person can drink a fifth or half gallon of whiskey and they can walk around and don't feel too intoxicated. While I also know other individuals who were not previously using any alcohol, and even one or two beers got them into trouble. And substances are sometimes used to cope with peer pressure or to deal with lack of belonging and acceptance. And family environment plays a key role, and lack of family supervision. But more than everything, it is the role model effect of the family. So, why do people get addicted? It usually starts as an impulsive act. A teenager, a young adult, somebody, they are in a party or in a family function and they say, I'll just try one. And when they try, they get a buzz or high, and then the reward system of the brain is changed. And then the reward system says, I liked it so much. Can I have some more? So the person goes in pursuit of more and more and more. Unfortunately, the brain develops tolerance. It seeks higher and higher substances or actions which will provide more and more dopamine for their buzz. So I want to spend more time on the issue of young adults, youth, because I think that has a significant bearing. So, what are the consequences of young adults, individuals before the age of 14, when they use alcohol and substances? There is poor academic performance. There is difficulty forming relationships. Excuse me. They have they have um, mm, difficulties with having a healthy self-concept. There are neurocognitive deficits, potentially impairing their memory, executive function, and impulse control. Individuals end up in juvenile justice system. There is violence and aggression in the family and in the community. So here is a very important number I hope you can take home with you. Approximately 47% of the people who begin drinking before the age of 14 develop a lifelong dependency on alcohol, compared to 9% of those who started drinking at the age of 21 or after. What does that say? That says that if your first drink of alcohol was after the age of 21, your risk of becoming having a diagnosis of alcohol use disorder in later life is 1 in 10, 9%, 1 in 10 almost. But if you started using alcohol before the age of 14, your risk of developing a lifelong diagnosis of alcohol dependency is 47%. It means 1 in 2, 50-50. There's 50% chance that you are going to end up having a lifelong dependency on alcohol. This is the key take-home message. Individuals who started using substances at a young age are at a much higher risk of becoming dependent on alcohol and other drugs in adulthood. They may experience more severe and chronic episodes of substance use. In plain English, it is difficult to treat such individuals. The prognosis is difficult. The outcomes are not very promising. I came across this and I just like the description that I want to read the last sentence in this slide here. The environment is like an artist who creates a sculpture by chipping away excess marble. And just like bad artists can produce bad art, environments with negative factors like drugs, malnutrition, bullying, sleep deprivation, and I would also add trauma, can lead to efficient but potentially harmful circuits that conspire against a person's well-being. In simple words, the early influences can change the brain circuits to the point that it becomes very difficult to change those connections in the brain. So what is the cost? What's the cost to the community? This is a slide basically to highlight that the substance abuse is a very serious issue in the community. These are overdose deaths in the US from 1999 to 2023. The line at the top is synthetic opiates. Synthetic opiates. What are we talking about? Fentanyl. The next line here is, excuse me, psychostimulants, particularly methamphetamine. What's the next line? This is cocaine. Then comes the benzodiazepines, the Valium, Ativan, Xanax, Klonopin, and then comes the heroin and the antidepressants. So the substance use disorders uh, lead to mortality as well as impaired quality of life in many individuals. So let's talk about recovery. What happens? How do people get better? Uh, the title of this slide is One Size Does Not Fit All in Recovery. In other words, every individual finds their own path to recovery, and no two paths are similar. There are similarities, but every individual has to find his own way of dealing with it. So, how do people come to seek help for it? Because there may be some health consequences, and maybe their primary care doctor, psychiatrist, their healthcare provider made recommendations that they should do something about their alcohol or cocaine use or opiate use. Or they come to us from the recovery court, which really facilitate those individuals who either don't see it or their substance use is so much out of control that they really don't have the capacity to sort of make changes And the recovery code is a very helpful concept in those individuals to meet the requirements of child protective services in some or in response to the demands of the employer who says, well, you've been missing work too often, you are late too often, your quality of work is deteriorating, and when the person's employment is in jeopardy, or due to family and friends' recommendations, significant other suggestions, because alcohol and substance use disorder or gambling disorder can affect relationships and actually can destroy relationships. So when these individuals come to us, many times people are not ready to completely quit. So it is perfectly acceptable to negotiate a path to recovery starting with harm reduction. So instead of drinking half a gallon of whiskey, can you cut back to maybe a fifth or a pint? Can we start working on cutting back? Because the thought of going completely sober for some people is very, very difficult. And if I had time, I would tell you that in my lifetime, in my professional career, I have come across people who have spontaneously given up their cocaine use or alcohol use. So what are the common approaches? There are medications that are used for uh, treating the withdrawal. Withdrawals can be very unpleasant and so difficult that people keep going back to drinking and using substances. So medications can help with withdrawal. Medication can help with cravings. Medications can help dampen the reward system at the other end. So for opioid use disorder, we use methadone, which is only available through federally mandated clinics. Buprenorphine can be prescribed by any prescriber in the community. Extended release naltrexone, which is Vivitrol, lofexidine, and for nicotine dependence, we use the nicotine replacement therapies, bupropion or Wellbutrin and varenicline. For alcohol use, we use naltrexone, disulfiram, which is Antabuse, and acamprosate. All right. So, what is the relationship of substance abuse with mental health issues? Do substance abuse issues cause mental disorders? Do mental disorders cause substance abuse? Excuse me. Uh, well, there's no clear answer. It is both. It is both. What we find is that an individual who comes to us for alcohol use disorder may have concurrent bipolar disorder, major depressive disorder, social anxiety disorder, post-traumatic stress disorder. Cannabis can be a precipitant of psychosis. I know a lot of our patients tell us if individuals diagnosed with schizophrenia, bipolar disorder, and even panic disorder, they come back and tell us, well, it helps me with my anxiety. Uh, and partly that may be true because the cannabis itself has so many different alkaloids, so many different chemicals in it, that some chemicals actually may be calming for the anxiety, but it is a fact that cannabis can and does precipitate psychosis, particularly in young adults, particularly in youth, and in adults in higher doses, particularly the paranoid kind of psychosis can be precipitated and perpetuated and exacerbated by cannabis use. Uh, uh, the substance use is very common in substance use can also precipitate bipolar disorder. And one theory says that in some families and some individuals, the part of the brain reward circuit, is dysfunctional, which means that they are born with low dopamine. that their system is not producing enough dopamine. So these individuals are kind of left at the mercy of using substances to bump up their dopamine in order to get some joy in their life. So when the person it comes to us, how do we approach? How do we help this individual? One of the more important, very, very important tools we use is called motivational interviewing. Before going into any details, I draw your attention to the last bullet here, which is called ambivalence. What is ambivalence? Well, ambivalence is a human condition where we human beings have two opposing feelings in our mind at the same time. For example, I want to change versus I don't want to change. Maybe I should give up these substances, maybe I shouldn't. So when it says I want to change, that is called change talk. And the part of the human mind that says, I, I'm not ready, maybe a little later, I'll think about it. That is sustained talk. The change talk and sustained talk, very important concept in motivational interviewing. So what is the concept? What is the motivational interview based on? Here is the bottom line. Motivational interviewing aims to evoke change talk in a compassionate setting. The basic idea is that the individual who comes to seek help, they have in their mind both sides of the equation. They have part of them wants to change, part of them doesn't want to change. So, what's our job as professionals? We start with affirming the patient's right and capacity for self direction. We facilitate informed choice. We don't make the choice for them, we ask them to choose their own path. It is guiding style of communication with particular focus on language of change. What do? We are evoking patients' own reasons for change. So I'm going to mention an individual I'm currently treating. This person was in a relationship. The relationship ended about 8 months ago. He had a job. Gave up that job. And he comes to us with depression. And he's drinking 2 bottles of wine a day. So he's a very nice gentleman, always keeps his appointments, doesn't always follow whatever I tell him to do, but he's a very nice guy. So I asked him, I said, I noticed that you always keep your appointments. To me, that means that you must be thinking about doing something about your condition and getting better. And he says, "Yeah, I want to get better." So I said, "What does getting better mean to you?" From there, we went into, uh, uh, well, do you think alcohol, what role do you think alcohol is playing in your life? Well, I know, he said, I know it's not good for my health. I have already acid reflux. I am having some liver issues. I know I need to do something about it. So there is the change talk. So then I said to him, uh, can we work on a plan? Can we look at what would you like to do about it? Can you pick a quit date? And his answer was very interesting. And he said to me, he said, it's football season. I sit down with my friends and, I drink when I'm watching football and I use a couple of bottles of wine a day. So I'm not going to do any changes until football season is over. So from there, the negotiation. I mean, the discussion was that uh, uh, obviously you want to change. Uh, so I put forth a hypothesis for him, and I said to him, uh, "Is it possible that you are kind of dealing with the consequences of breakup in your relationship, you're leaving your job. Is it possible that that has left you kind of lonely? And now this is drinking is filling that void, and then you think this is the only way to socialize and be with your friends. And he kind of confirmed that. He said, "You're right." Motivational interviewing aims to clarify patients' values and amplify the discrepancy between their values and behaviors. So, on one hand, you want to do something about your drinking, but on the other hand, you are telling me that you're going to continue drinking for the next 3 months when the football season is going on. Most motivational interviewing contrast with authoritative. We don't confront people. We are not argumentative. We use collaborative partnership to have the patient tap into their own motivation. What do? We engage, we focus, we evoke, we do planning, and we use open-ended questions. We use affirmations, reflections, and we provide summaries. And it is the foundation of motivational interviewing, forming a reasonable guess as to the meaning of patient statements, what are the meanings, and giving voice to this guess. So I talked to my patient and I said, is it possible that you are drinking 2 bottles of wine a day because you're so lonely and you think this is the only way to socialize? That was a hypothesis, and he confirmed it. Realize that what you believe or assume, people assume people to mean is not necessarily true. They may have different meaning. Any statements by the patient that indicates that the patient is motivated should be reflected back. Motivational interviewing. So at the end, we ask the patient, how did I do? Am I understanding you correctly? Did I miss anything? Do you want to add anything? Motivational interviewing focuses on plan for change. When the commitment language starts, that's when you start making a plan. You ask for a quit date, reasons for making the changes. Why do you see yourself making these changes? Uh, Make a change plan, and you want to leave the patient with hope and optimism. So, effective treatments is possible. Medications are used for treating withdrawal, minimizing or eliminating cravings, dampening the reward of substances, staying in treatment, preventing relapse, and treating concurrent mental illness. Uh, so, what are different non-medication options? Cognitive behavioral therapy, contingency management, motivational enhancement therapy, family therapy, 12-step facilitation. Contingency management. Let's say a lady is pregnant, she's smoking cigarettes, and she's also using methamphetamine. And you sit down and we are talking, and she says, I know I should do this, but I just can't get away from it. I can't stop it. One of the most effective strategies in this situation would be to set up a reward system, which will work like this. The lady comes to the clinic, she provides a urine specimen, and if the urine specimens are consistently negative of cocaine and nicotine metabolites, then she gets a voucher or a reward. Uh, so, uh, in time limited situations and under certain circumstances, contingency management, particularly for psychostimulant abuse, has found a good place. So, uh, are psychedelics good for treatment of addictions? Well, there is a lot of excitement that there is a potential for using psilocybin for alcohol use disorder, tobacco addiction. FDA has actually given psilocybin as a breakthrough therapy designation for treatment of depression. In other words, research is ongoing. So why is this treatment approach not widely available to community? Well, there are problems. The use of psilocybin on a long-term basis causes cardiac arrhythmia, cardiac arrest, which means death, cardiomyopathy, and more importantly, valvular heart disease or cardiac fibrosis. So these are the reasons that the psilocybin is not becoming a mainstream treatment approach. Ketamine also has potential for alcohol, heroin, and cocaine use disorder. One of the treatments that I want to mention is transcranial magnetic stimulation. What you see is a lady sitting in a chair. It looks like a dentist chair to me, and she's reclining. And the treatment provider is bringing in a magnet. There are three, four types of magnets that are used. I'm not going to go into any details, but those magnets are brought close to certain areas of the brain. So for depression, you use a different site of the head. For obsessive compulsive disorder, you use another site of your head. For addictions, you use another side of your head and different type of. So it takes anywhere from 20 to 30 to 40 treatments with this approach. So what is it used for? It is FDA approved for major depressive disorder, obsessive compulsive disorder. And FDA has cleared RTMS for, guess what? Tobacco addiction. It is being used. Now, the research shows that this treatment alone used for tobacco addiction is not very promising, but if you use it with other like varenicline or Wellbutrin, your success rate goes higher. It targets reward pathways, reduces cravings, and improves decision making. And research is ongoing for its use in severe alcoholism and opiate addiction. So let's summarize. The bottom line message is that addiction is a brain disease. We have seen PET scans showing changes in the brain. We have seen neurochemical changes, which produces structural and functional changes in the brain. It has to be treated like any other chronic disease, like hypertension, diabetes, asthma, COPD, without any stigma. Public health model to inform, educate, and inspire the community for recognition and respectful treatment of substance use disorders is important. We have to spread the message of hope. Recovery is definitely possible, as I demonstrated in one of the slides, that if a person abstains from using methamphetamine or cocaine, there are actually changes taking place. Recovery can be seen in the PET scans. Be aware of the significant risk of initiation of substances before the age of 14 and its serious consequences. What can one thing that can make a difference in a person's life? Do everything you can, the community, the family, the school, to avoid any initiation of tobacco, alcohol, cannabis, cocaine, methamphetamine, any other abuse before the age of 14. That can make a lifelong difference in this person. And finally, we need to advocate for continued research for more better and more effective treatments. With this, I conclude my remarks, but I am available for any questions. Thank you.
All right, we do have a few questions in the chat. First one's from Marla, and she says, is there any type of test for genetic predispositions?
Very good question. To my knowledge, there are no tests available clinically, but we do know, take the example of alcohol use disorder. And in alcohol use disorder, the alcohol is metabolized in the body by an enzyme called alcohol dehydrogenase. And there are some families where genetically this enzyme is low, which means their ability to tolerate that even a small amount of alcohol affects them a lot. We know that at a clinic, in research level, but to my knowledge, that enzyme assay is not available clinically as of now.
Okay, and this, you may have answered this a little bit. Sharon's asking, is there a gene for addiction?
There's no one single gene for addiction, but it is a complex interplay of different genetic dispositions. Uh, for example, going back to the example of alcohol, if a family has, there is a gene that makes alcohol dehydrogenates. Let's say a family has two copies of that gene. It happens. So now this family is making too much of this enzyme, and that has consequences. So there is no single gene that explain all the addictions, but there are different genes and there are complex interactions that can lead to the pathway of addiction.
Okay. And John asks, why is it that addiction probability increases to 47% for those who start before age 14? Is it like you said, there are just brain connectivity changes, or is there more to it?
Excellent question. I'm glad you asked that because I should have explained that a little bit more. Here's what's going on. The human brain starts developing starting at even before birth and during childhood, and it keeps on growing. Now, as a teenager, what happens is the brain goes through a process called pruning, literally pruning, which means the brain is shedding off or cutting back on many of the neurons in a young person's brain, particularly in the prefrontal cortex. Uh, so, what we are saying is that the brain is developing connections. The brain, think of it as going back to the example of sculpture. The brain is being sculpted by the biological processes, and some parts of the brain are being pruned. That's a good word, pruned. They being removed. The brain is the brain of a teenager, actually the frontal cortex is actually thinner because of this pruning. So the as the brain is developing and some changes take place at that time and substances are introduced at that stage, uh, they tend to become tenacious. They kind of become ingrained in that developing brain. And so it is difficult to, uh, it is a challenge to treat those individuals whose addiction started before the age of 14 because they are so deeply ingrained and so um, uh, structurally part of the system that it is difficult to change. So the brain of a teenager is a developing brain, and think of a sculpture, and somebody is sculpting, and the sculptor chisels out something that should have been there. That stays with the sculpture for as long as the sculpture is around. So it's that kind of that basically the brain develops certain connections which are difficult to get away from.
Okay. And a little more on that subject. Joy asked, define further the started drinking alcohol. Does this include someone that had alcohol even just one time in abundance? An example is a 13-year-old drinking a bottle of wine with friends at a sleepover and then did not drink again until a couple times at 17 years old and then not again until after 21 years old. Would something like that be included in the stats for under 14-year-old? Or would they need to have consistency with the consumption?
Very good question. Obviously, in the example that you present, this will be considered a very sporadic, controlled, occasional use of alcohol, which is spread far between. This is not developing. Uh, the one key thing I would look for in that situation is when repetitive use of any substance before the age of 14 develops tolerance. Tolerance. Um, for example, if a teenager starts drinking one glass of wine or one beer, and a few weeks later he says, one beer, what is this? I'm not getting the buzz. I need to drink two beers. And by the time he's a senior in high school, he's drinking a six pack. That is the kind of individual that would be more prone to develop a severe alcohol use disorder, and it will be a difficult prognosis.
Okay. And Marissa says, I heard you mention a type of choline. I have heard of supplements like, I'm not going to say this right, I'm sure, choline to help support brain functioning. Would supplements like these help dopamine in any way to help with depression, which maybe could help with addiction?
Good question. So, what I was talking about was, so when a person is using tobacco, smoking, what does that do? The smoking goes to the a system in the brain called acetylcholine. Acetylcholine is a neurotransmitter in the brain, in our muscles. It's present in many parts of the body. Uh, so the acetylcholine, there are two types of receptors, nicotinic receptors and muscarinic receptors. So the nicotine in the smoking goes to the nicotine receptor and starts a chain reaction that leads to release of dopamine. Coming back to your question, uh, there are uh, 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 there are some reports that use of some cholinergic compounds can help situations like uh, cannabis use. However, this concept has not been proven in rigorous studies. Does it help with depression? A lot of people believe that, but the scientific evidence to support that is minimal. The only scientific evidence that kind of supports the idea of using herbal medicines for depression is St. John's wort. It does have some properties which are actually similar to some of the medications by increasing serotonergic neurotransmission in the brain. So, if there is St. John's wort has more evidence than any other botanical or natural supplements, to my knowledge.
Okay. I was just looking back through the chat just to make sure we didn't miss anything. There's a lot of thank yous and in there and great presentation. Um, but I think that was all for questions.
I thank everyone for your attention, and I hope you enjoy the rest of your day.
And thank you, Dr. Saeed. We appreciate you coming and sharing your time with us. And I want to thank everyone for joining us today. We hope the information was both valuable and useful to you all. Today's presentation is just one of many webinars being offered throughout September as part of the Recovery Summit. For details and registration for upcoming sessions, please visit our website at www.sccmh.org under the Events tab. Also, keep an eye out for a short survey in your email. Your input is vital in helping us continue to improve and shape future events, such as the Recovery Summit. For those requesting McBAP and PURE certificates, they will be emailed out in mid-October. If you're requesting social work CEs, your certificates will be emailed out to you after payment is received, and the invoices will be sent out, hopefully starting soon, but soon, hopefully, or in October, the beginning of October. Thanks again for joining us today. We look forward to seeing you all next time. And thank you again, Dr. Said.
You're very welcome. Take care.